Type 2 is the most common type. It's caused by not enough insulin or insulin resistance. Many tissues are resistant to insulin. There's a reduced number of insulin receptors, or the insulin receptors are less responsive. Type 2 has several comorbid conditions. That means problems that go along with it. Obesity, coronary artery disease, dyslipidemia, lipidemia, that has to do with the fats, cholesterols in the blood. So there's something wrong with the cholesterols that are in the blood. Hypertension, microalbuminemia, enhanced conditions for embolic events. These folks are more likely to have blood clotting problems in the legs and the lungs, that kind of thing. These comorbidities collectively are called metabolic syndrome, or insulin resistance syndrome, or syndrome X. Diabetes is very much a vascular problem. There's long-term complications for patients with diabetes, and they are basically vascular in origin. They're macrovascular. That means atherosclerotic plaque inside the vessels. We've got problems with plugging up coronary arteries and cerebral arteries and peripheral vessels. What does that mean? It means you got less blood flow everywhere. And microvascular changes, capillary damage, again, have problem with circulation or leaky vessels, retinopathy, neuropathy, nephropathy. Gestational diabetes is hyperglycemia that develops during pregnancy. It's got to do with a carbohydrate intolerance that sometimes occurs during pregnancy. And sometimes this is treated with just diet and exercise, but quite often ladies with this end up getting insulin, because if blood sugar is not controlled, it's associated with prematurity, miscarriage, and birth defects. This carbohydrate intolerance usually goes away after delivery, but 30% of the women who have gestational diabetes develop type 2 diabetes within 10 to 15 years. Screening: fasting plasma glucose, FPG, which quite often people call FBS, fasting blood sugar. Same thing. Levels higher than or equal to 110 milligrams, but less than 126 may indicate pre-diabetes. So, you get somebody between 110 and 126, you're thinking, we may have a problem here. We better be watching, trying to make any kind of weight management issues, dietary issues, exercise issues to try and prevent or at least delay the onset of plain old diabetes. We also screen for this using a glucose tolerance test. Treatment. Type 1 is insulin therapy. Yes, you do want to make diet changes, and yes, you want to make suggestions about exercise and weight and all of that, but insulin is your bottom line for type 1. Type 2 diabetes. The first thing we're going to do is make lifestyle changes. That's diet changes and exercise changes. Encouraging people to exercise. If that doesn't work, then we'll move to oral drug therapy, oral anti-diabetics. And if that is no longer providing control, we move on to insulin. We have multiple kinds of anti-diabetic drugs. We have the insulins, we have the oral hypoglycemics, and both of them aim to produce normal blood glucose states. That's what we're trying to get. Okay, remember we have endogenous and exogenous insulin. Endogenous is what the body produces itself. Exogenous means it's what we get in the vial that we inject into people. The exogenous stuff is what we give people, but we want it to work like the endogenous insulin. We want to end up with the same blood sugar levels and the same functionality of the body. And we're trying to restore the body's ability to metabolize carbohydrates, fats, and proteins within the normal way, to store glucose in the liver, and to convert glycogen into fat stores when it's needed. Some insulins are derived from porcine sources. Porcine means pig. But most of what we give now is human-derived using recombinant DNA technologies. But regardless of the type of insulin, we are aiming to get a tight glucose control. To reduce the incidence of long-term complications, you need tight glucose control, which means we want it as close to 100. Blood sugar as close to 100 as we can get. Human-based insulins come in various types. We have rapid-acting, short-acting, intermediate, long-acting, and a combination insulin products where there's more than one type within the vial. But keep in mind that short-acting insulin is the only insulin product that can be given IV bolus, IV infusion, or IM. Short-acting insulins include regular insulin. And I'm going to refer you to the handout that has a nice chart on how long all the different insulins last and when they peak and what's the duration of each. But this is a diagram that I pulled off the web that shows the same thing. Over on the left-hand side of the chart, you see the rapid-acting insulins. You can see they have a pretty high peak action. They work really fast and they work really hard. So they will bring down blood sugar pretty dramatically. In most instances, this is not what you want because it works fast and then it's gone. Regular insulin is going to last up to about 12 hours and it doesn't peak quite as quickly. Quite as hard. NPH is kind of in the middle there, and then we've got glargine, which you can see lasts over 24 hours. But when you look at the long-acting insulins, you see you don't get a very strong response, but you get a continuous response. So if you combine a short-acting with an intermediate or a long-acting, you get the short-acting is going to cover the meal that they eat right away, and then the other stuff is going to provide them coverage throughout the day. Sometimes we give insulin by a sliding scale, and we're going to use short-acting or regular insulin adjusted according to the blood glucose test results. Typically we see this in hospitalized patients who maybe they're just starting on insulin, or maybe they've got something else that's putting their diabetes out of whack and we're not sure what to do. So you test their blood sugar 2 hours after they eat, or you test it as a fasting, and then you go look at the orders and it says if their blood sugar is 120 to 150, give them 10 units. If it's 150 to 200, give them 15 units. It's going to say something like that. So the results, the actual blood sugar results, is telling you how much insulin to give. We also use this type of sliding scale for people who are on TPN or enteral tube feedings.